Today I am going to discuss about post-amputation limb pain management. In 16th century, Dr. Ambrose noted an unusual complications from the patients. The patient said following amputation of his arm, he still felt that arm is there. Dr. Ambrose is one of the military surgeon, lot of amputation done by him. Initially he thought it may be due to part of psychiatric illness. There is psychiatric illness called schizophrenia, sometimes associated with nihilistic delusions. In that case, patient complaining the present body part as missing, but here the absent body part they identify as present. So it happened in the other way around in the schizophrenia, but he thought it may be due to some psychiatric or some mental disorder in the patients. But he did the several amputation. Most of the patient complaining the same symptom. Then he was so surprised. He tried to identify the thing behind that, but unfortunately he failed. Then he said some kind of enigmatic thing is there. Even after amputation my patient hand, still patient can feel the distal limb. Still patient can feel the distal limb. Not only feel, patient can even feel the pain of the distal part of the amputation. That or amputated part pain patient can still feel. When I was in the medical school, I also had same complication with the patient. Patient complaining even after amputation, patient still feel the distal part is there. Then I want to investigate what happening is there. For that, now I am going to do an experiment. Who want to be guinea pigs? Yes. You are the one I am going to take as a guinea pig. I am taken you are into my ward. This is the patient. I am going to cut his patient arm. I am going to cut his patient arm. I am going to cut this arm as well. Right and left both arm. Not only that, I am going to cut both lower limb. I am going to cut both lower limb. It is not a good thing to cut the whole limb in the patient, but for the experiment wise, I am going to cut right upper limb, left upper limb, lower limb, both lower limb. In here, in this cut arm, patient develop acute stump pain. Immediately after removing the arm, patient complaining pain. I investigate why is that. Then I found to have tissue trauma and inflammation. Tissue trauma and inflammation. Inflammation lead to acute stump pain. Tissue trauma and inflammation lead to acute stump pain. Then I treat that stump pain. This limb also patient developed acute stump pain. I treated with antibiotic. Then inflammation and tissue trauma and infection resolved. After about 3 months, patient is still complaining pain in the lower limb. Patient is still complaining pain in the lower limb. That is also some kind of stump pain. Because of that, I am going to call it as chronic stump pain. Here, acute stump pain immediately following the surgery, chronic stump pain after 3 months of the surgery without inflammation or tissue trauma. Then I investigate why it is due to. Then I found to have some bone spore. Some bone spore are remaining in the amputated stump part. Lead to pain. Not only that, some tissue calcification is there. Tissue calcification also lead to pain. Not only that, sometime in the stump site, there can be arterial insufficiency. That arterial insufficiency lead to chronic stump pain. Arterial insufficiency. So, patient can develop acute stump pain, patient can develop chronic stump pain. Chronic stump pain definition is patient feel pain after 3 months of amputation without features of tissue inflammation and tissue trauma right now. After that, I remove patient this limb as well. In this limb, patient develop phantom limb sensation. That means even after removing the lower limb, patient felt still that removing part is there. Even after removing the lower limb, patient still felt that removing part is there, but no pain at all. Because of that, I am going to call it as phantom limb sensation. Here the hallmark is, even though patient feel that lower limb is there is no pain at all. No pain. In this stump or this amputated side, patient develop phantom limb pain. Here, patient felt the distal part. In addition to that, patient complaining pain from the distal part. This pathophysiology of these two is obvious: tissue trauma and inflammation, bone spur, tissue calcification, and arterial insufficiency. What is the pathology behind the phantom limb sensation and phantom limb pain? I want to investigate that. What I am going to do is, I am going to take this stump into here. Here my stump. I am going to enlarge that stump for you and look through microscope to see what happened there at the nerve ending, cut nerve ending. Here your nerve is there. During the amputation, this part is cut and removed, distal part cut and removed. I am going to enlarge it. Here your nerve ending. Actually what happened is, nerve ending is little bit enlarged. And there is thing called neuroma formation. The causes for neuroma formation, then I find causes for neuroma formation, they found to have tissue inflammation and deafferentiation, removing from the lower impulse, deafferentiation lead to neuroma formation. Tissue trauma and deafferentiation lead to neuroma formation. Then what I did is, I enlarged further in this neuroma area. What I found is, there are large number of sodium channel than usual. The amount of sodium channel is more in the neuroma. Because of that, time to time sodium jump into inside. Once sodium come into inside, they can create action potential. Even with the minor stimuli, neuroma can stimulate and the action potential can generate. Not only that, even without stimuli, some sodium can jump into inside and the neuroma can stimulate and subsequently action potential generate. This happened because no impulses coming from the distal area, because now this area is not there. Because of that, this area are modified in such a way to receive maximum impulse from the down or amputated part. Because of that, it increased the number of sodium channel. Here, large number of sodium channel. Then I went through the nerve to see what happened in the spinal level. I want to see what happened in the spinal level. The cell body of this neuron is situated in the posterior root ganglion. Then this cell must be either a C fiber or A delta fiber. The fibers responsible for pain is A delta fiber and C fibers. Cell body is situated in the posterior root ganglion. It enters into the spinal cord via posterior root. Here your central canal. Then these nerve fibers coming from here relay in your substantia gelatinosa. Truly speaking, mainly area 2. Or some book says lamina 2. it relay in the laminar toe. With the amputation, what happened is the impulses come from the lower part is now reduced. Because of that, laminar toe now increase the size in order to capture the signals. Amount of signal coming from this side is reduced. Because of that, size of the laminar toe going to be increased. The laminar toe size is going to be increased. In addition to that, each and every level of your spinal cord receiving inhibition from the higher center. Receiving inhibition from the higher center. With the deafferentiation from here, the inhibition from the upper level also now going to be reduced. They are going to reduce inhibition. Upper inhibition reduce, increase the laminar toe size. After that, this laminar toe containing NMDA receptors, N-methyl D-aspartate receptors, amount of receptors which present in the laminar toe also going to be increased. Amount of receptors which present in the laminar toe going to be increases. Those laminar toe area can be stimulated by, truly speaking, NMDA receptors can be stimulated by tachykinin, neurokinin and substance P. Those NMDA receptors can be stimulated by tachykinin, neurokinin and substance P. Because of now your patient having large amount of NMDA receptors, even with the small amount of tachykinin, neurokinin and substance P, this area can be stimulated. This area can be stimulated. Those are the things happen in the spinal cord level. Then I went to see the higher level. What happened in your cortex? This fiber goes into the other side, just in front of the anterior canal, sorry, central canal, then ascend via this tract. This ascending tract, this is your brain cortex. This ascending tract go and relay in your thalamus. In addition to that, some fibers go into your limbic system. Some fibers go into your somatosensory cortex. Somatosensory. What happened when you remove limb is, because of lesser number of impulse from to the somatosensory cortex, somatosensory cortex is very upset right now because they received lesser number of impulse. Because of that, the adjacent area also now ready to identify if impulse come from the amputated stump. What happened is, immediately adjacent area to the area which is responsible for amputated part now ready to accept impulse from amputated stump. So immediately surrounding area to this amputated area is now ready to accept impulse from the amputated stump. This is called neuroplasticity. Patient develop condition called neuroplasticity. In the central level, first thing happen is neuroplasticity. After that, there is a well organized system in your brain. If they receive impulse from here, it go into thalamus, and part of them go into limbic system, part of them go into primary motor cortex, somatosensory cortex, like that. Well organized neuromatrix is there in your body. Well organized neuromatrix. What happened when this area also accepting impulses from the amputated stump? Now that neuromatrix going to be upset. Previously it went here. Now it should went here as well. So abnormal neuromatrix is there right now in your body. Abnormal neuromatrix. Not only that, abnormal neurosensing also there. Here the sensory sensing part also little bit abnormal. Abnormal neurosensing. So what happened at the cortical level is they develop condition called neuroplasticity. They develop condition called abnormal neurometrics, abnormal neurosensing. This thing happen not only somatosensory cortex, motor cortex as well. Somatosensory and this thing happen in the somatosensory cortex and motor cortex. I will repeat what happened in the phantom limb. Number one, at the level of injury, neuroma formation happening. With that increased number of sodium channel, which was happened in the C fiber and L fibers in case of phantom limb pain. Even with the minor stimuli or without a stimuli, this nerve membrane can stimulate. The impulses can travel into your laminar 2. Laminar 2 size also now increase. In addition to that, central inhibition reduced and NMDA receptors also going to be increased. Because of that, tachykinin, neurokinin and substance free now can freely act because larger number of receptors is there in your laminar 2. At the central level, what happened is neuroplasticity is there, abnormal neurometric is there, and abnormal neurosensing is there. So then I want to know who are the people having high risk of developing phantom limb sensation or phantom limb pain. Why I want to know is what they found is even though you remove arm or lower limb or when we do the amputation, 78% of people will get the phantom limb pain or phantom limb sensation. That means 22% of people, patients, not getting symptoms, no phantom limb. So because of that, I want to find who are the people which having high risk of having phantom limb pain or phantom limb sensation. If your patient having high intensity preoperative pain, that means before amputation, if your patient having high pain in the amputation site or distal site, those patients are having high risk of developing phantom limb sensation or phantom limb pain, pre-op pain. And upper limb give rise to more phantom limb sensation or phantom limb pain than lower limb. Upper limb associated with more phantom limb pain. Female gender also, yes. Female gender associated with high incidence of phantom limb pain. Some genetic predisposition is there. In addition to that, if you are patient having anxiety or depression, it will increase the incidence of phantom limb pain or phantom limb sensation. The risk factors for developing phantom limb is pre-op pain, upper limb surgeries, female sex, some genetic predisposition is there, anxiety and depression also associated with high incidence of phantom limb pain. Now I want to find a way to reduce the phantom limb pain or developing of phantom limb sensation. For that, what I am going to do is I am going to reduce the risk factors. I am going to add additional drugs to reduce the incidence of phantom limb pain. Preoperatively, what you can do? You can educate your patient. Why? Because anxiety and depression associated with high incidence of phantom limb pain. Once you educate, you can reduce anxiety, you can reduce incidence of depression. In addition to that, preoperative pain also adversely affect with phantom limb sensation or phantom limb pain. So you can start preoperative analgesia. Number 2, you can start pre-op analgesia. The researchers found if you are able to start epidural infusion prior to lower limb amputation, 24 hours prior to lower limb amputation, and if you can continue it more than 72 hours, or at least 72 hours, it associated with lesser incidence of phantom limb pain. So, pre-op analgesia, if you are going to start epidural, you should start 24 hours prior to surgery, or in case of upper limb amputation, you can start brachial plexus block or brachial plexus catheter 24 hours prior to surgery as a preemptive analgesia. During the intraoperative period, if your patient uses on regional anesthetic technique like epidural or brachial plexus catheter, you can continue. Otherwise, you can start regional technique on top of the general anesthesia, or you can start regional block per se. So you can start regional anesthetic and analgesic technique. Regional anesthetic and analgesic technique. Number 2, you can start ketamine infusion during the surgery. Ketamine infusion. If you remember what happened at the spinal level is, it increased the number of NMDA receptors. Ketamine is one of the drugs which block the NMDA receptors. So, if you are able to start ketamine infusion, it will reduce the incidence of developing phantom limb pain. So, you have to start ketamine infusion and you have to continue it at least 24 hours. So, your patient now regionally anesthetized, you started ketamine infusion. In addition to that, you can consider simple analgesic like paracetamol and non-steroidal anti-inflammatories you can use. Non-steroidal anti-inflammatory drugs, and if you think your patient need additional drug, you can start strong opioid. Patient control analgesia or regular dose of morphine you can prescribe. Patient control analgesia or regular dose of morphine you can prescribe. During the post-operative period, what you can do is, if you are patient on regional anesthetic technique, you can continue it. Continue regional technique. What this is if your patient having epidural catheter or brachial plexus catheter, continue it for 72 hours at least. So here the continuation of epidural continuation. You can start paracetamol and non-steroidal anti-inflammatories. You can consider strong morphine, PCA or regular dose like previous. You can consider calcitonin and gabapentin sometime. Calcitonin and gabapentin. They have found out the calcitonin and gabapentin reduces the incidence of developing phantom limb pain. In addition to that, you can start lignocaine infusion or antidepressant. But unfortunately, IV lignocaine and antidepressant, the available current data says does not reduce the incidence of phantom limb sensation or phantom limb pain. Because of that, currently we are not using lignocaine or antidepressant in the management of phantom limb sensation or phantom limb pain. If your patient on ketamine infusion, it also can continue for 24 hours during the post-operative period. Infusion. Those are the drugs management or pharmacological management which available to reduce the incidence of phantom limb pain or phantom limb sensation. Then I am going to tell you about some non-pharmacological management. Of phantom limb sensation or phantom limb pain. Number 1, graded motor imaginary. What is the meaning of graded motor imaginary? Graded motor imaginary. What you can do is, what they say is, if when you having pain, your brain a little bit failing in identification of site of pain properly. Your brain is little bit of failing identification of site of pain. That is called right-left discrimination. Number 1 you can do is right-left discrimination. Left-right discrimination. Number 2. Once we amputated your limb, what you can do is you can think of movement of that arm. Actually, you can't move, but you can think. Even with the thinking, 20% of your brain fibers going to fire. 20% of your brain fibers going to fire even with the thinking. Thinking about movement. Even with that, 20% of brain fibers going to fire. Then brain fibers said, my arm is there, 20% always firing. Because of that, no need to become plasticity. No need to become abnormal neurometrics formation. No need to become abnormal sensing. My arm is there. By that way, you can reduce the development of plasticity and neurometrics, abnormal neurometrics generation and abnormal neurosensing generation. Even after removing the arm, you can think, now I am going to move my arm, now I am going to move my arm, now I am going to move my arm. With each and every thinking, nearly about 20% of your brain fibers going to fire. Number 3, you can do mirror therapy. In mirror therapy, what happened is, this is your mirror. When I keep my arm here, my normal arm here, I can see the mirror image from mirror side, mirror image. What I am going to do is, my amputated arm I am going to keep behind the mirror and the normal arm I am going to keep front. When I look through mirror, what I see is my amputated part also there. Amputated part is, I can see as present. My amputated part I can see as present in the mirror image, but in the brain, what happened in the brain? Brain cell think your arm is there. It's a nice thing. Brain thing is still think your arm is still there. Because of that, brain think no need to become neuroplasticity because his arm is there, and no need to make abnormal neurometrics because his arm is there. I see. My eye also sees. No need to become neurosensing, abnormal neurosensing. Your arm is there. Because of that, the central process is going to be reduced. Central neuroplasticity, abnormal neurometrics formation or abnormal neurosensing now going to be reduced with the mirror therapy. In addition to that, there are few other novel drugs which can try in patient with phantom limb. You can give botulinum toxin. What happened with the botulinum toxin is they going to degenerate your nerve, called chemodegeneration. Botulinum toxin. Or chemodegeneration of nerve. Number 2, you can do selective radiofrequency ablation. Selective radiofrequency ablation of the nerve. Radiofrequency ablation. Number 3, you can do monoclonal antibody based treatment. What? Monoclonal antibody based treatment. Very good. Monoclonal antibody based treatment. You can create an analgesic drugs specifically target your nerve by using monoclonal antibody. Currently, they are investigating those drugs. Type 1 studies or level 1 studies complete now. The drug is called, disease is called osteoarthritis and back pain. For the osteoarthritis and back pain, now they are going to start a drug which combined with monoclonal antibody to treat the pain. Near future, it will available for treatment of phantom limb pain as well. That is all regarding the phantom limb pain and phantom limb sensation management. Thank you.